I talked about the product. It's the same product, and of course most of the patients on study were myeloma patients. And after we give 6 patients 150 million cells and another 7 patients 450 million cells, we stopped at 800 million cells for the next patients in the phase 1A, and the phase 1B and 2 continued this dose because this is like a kind of a target dose that we saw that it's very effective and not more toxic than the previous doses. Again, starting from safety, CRS was very frequent, like in all CAR T studies, but overall manageable, mostly grade 1-2 with frequent use of tocilizumab. We had only 2 cases of ICANS out of 50 patients, so only 4%, and they were both mild, one grade 1 and one grade 2 ICANS, and it's much less compared to other CAR T, fortunately. Hematological toxicity occurred and were of course very frequent, and some were durable, unfortunately quite similar to other CAR T, and we didn't see any new signals of toxicities that are not known from other CAR T. Response rates was again very high, 90%, most of it 78% complete response, 70% MRD negative, and the durability was quite comparable to other CAR T. PFS is close to a year, 334 days. Again, in a very heavily pretreated populations with 4 prior lines of therapy. And I think the take-home messages from this, it's not new. CAR T is efficient for myeloma. We already have 2 FDA-approved CAR T with a lot of experience, but the problem is slot, right? So only I think about a quarter of patients in the US can get CAR T. I think this is the estimate, not to mention other places in the world. So the message is that we can produce academic CAR T and more patients can get their CAR this way.